Today we are going to conduct the Viva practice training on prostate cancer. Many thanks for the trainee who has joined us and also volunteered to record. The recordings are very useful for further revisions and also for training the other exam going trainees. Welcome to this training session. Can we jump into the prostate cancer scenario straight away?
Yes.
Good. You got a GP referral letter stating that the GP has referred the patient because of increased PSA, say at 4.8. What parameters you will look into it when you receive the letter?
I'll look at the guidance from NICE on prostate cancer, and these state that from primary care, if the PSA levels greater than 3.0 in a male aged between 50 to 69, then this warrants an urgent referral to secondary care for suspected cancer.
Okay. Okay, good. So the main things you'll be seeing is the age, any patient comorbidities, and whether the patient's PSA level is really abnormal for the specific age range. How will you decide the normal PSA based upon the patient's age?
This will be based upon the Osterling age-specific ranges. So if the patients were between 40 to 49, the PSA should be less than 2.5. This value should be less than 3.5 for a patient between 50 and 59, less than 4.5 if they're between 60 and 69, and less than 6.5 if they're above the age of 70.
Okay, does this belong to any specific guidelines or how you got these values?
So these formed part of previous guidelines in terms of, and they're also from the EAU guidelines. They are from Ostling's paper as well, but they're from from Ostling's paper.
Okay. Osling's age-specific range is slightly different to what you have said. What you have said is also present in few guidelines. You can follow any of them, but you should know which one you are following. Osling's is much more very easy to follow. For example, it starts at age 40 to 50, and then 50 to 60, and then 60 to 70, and then 70 to 80. Above 80, there is no real normal age range, PSA range. As you know, we need to take it based upon the patient's performance status. So 40 to 50, 50 to 60, 60 to 70, 70 to 80. Four groups you have. Four numbers you need to remember are 2.5, 3.5, 4.5, and 6.5. Just omit the 5.5. It's much more easier and very easy to remember. When you revise these recordings in YouTube, I will try to post the specific slides so that it's very easy for you to revise also. Okay, this patient you are seeing in your rapid access clinic. And so what main things you will go through with the patient? This patient's PSA, as I said, is 4.2. His age is 55. Otherwise, he's quite fit and well.
I will establish the patient the reason why the PSA was measured, whether as part of a health check by the GP or any symptoms such as LUTS, visible hematuria, erectile dysfunction, whether he's got any symptoms suggestive of advanced disease. I'll confirm if he's had any UTIs. I'll establish his past medical history and general fitness for surgery, and I'll establish whether he has a family history of prostate cancer. So those are the things in the history that I would want to confirm with the patient.
Okay. Do you know what are all the NICE guidelines criteria for referring a patient for prostate cancer PSA referral for the GPs?
So based on the PSA, the current NICE guidance from 2019, the latest guidance states that referral to primary care from primary care should be made if the PSA is 3.0 nanograms per liter, nanograms per mil or above in a man aged between 50 to 69.
Okay. In what conditions a GP should need to do the PSA as per the NICE guidelines?
It's recommended to measure the PSA in the presence of obstructive LUTs, visible hematuria, erectile dysfunction, or any signs or symptoms suggestive of advanced prostate cancer, such as bone or back pain or systemic symptoms. It is also advised that the PSA should be measured if the patient requests it, but after the appropriate counseling has been carried out.
Okay. The only small change is it is not obstructive LUTs, it is any LUTs. It could be a voiding symptom or it could be a storage symptom, mainly including nocturia, urinary frequency, hesitancy, urgency, anything. And
Okay.
don't use the word obstructive LUTs in any table. The correct term is voiding LUTs. Okay?
Yeah.
Yeah. You said about you will ask about his family history. What is the importance of it?
Hereditary prostate cancer accounts for 9% of all diagnoses, and the relative risk of developing prostate cancer changes depending on how many family members are affected with the condition. If one family member has been diagnosed with prostate cancer, then the risk is twofold. This risk is fourfold if two first-degree relatives have been diagnosed with the disease, and the risk is 5.5-fold if this is thought to be hereditary prostate cancer. So that's where either three first-degree relatives have been diagnosed with prostate cancer, or where you have two relatives diagnosed before the age of 55.
Okay. Any specific gene you are aware of?
Sorry?
Any gene which is related to prostate cancer?
So the chromosomes which are implicated in prostate cancer include the BRCA2 gene on chromosome 13, the HPC gene on chromosome 1, and the MSR gene on chromosome 8.
That's quite nice, detailed answer. Tell me about PSA.
PSA stands for prostate specific antigen. It's a serine protease, glycoprotein protease, which has a molecular weight of 34 kilodaltons. It's otherwise known as human kallikrein 3, and it's secreted, produced by the prostatic ductal and epithelial cells. Its function is to liquefy the semen coagulase, and it is secreted in normal quantities by the prostate cells. It's encoded for on chromosome 19.
Okay. So this patient is asymptomatic and he had his PSA tested. Is it like a PSA screening? What is your view on prostate cancer screening?
So prostate cancer screening using the PSA, but in the UK currently there is no nationally organised screening programme, and this is due to controversies with using the PSA to screen for prostate cancer. PSA has a high sensitivity but low specificity in detection of prostate cancer. In terms of the evidence for PSA screening, the two main trials which looked at this were the PLCO trial in the USA and the European randomized study for screening in prostate cancer. The American trial found found that PSA screening made no significant difference in terms of disease-specific and overall survival, although that study had a number of limitations. However, the European study found a significant reduction in disease-specific survival with a reduction of 20%, and found that the number needed to screen at 16 years in order to prevent one death from prostate cancer was 16.
Is there any criteria available to decide a disease is suitable for screening?
So there are the Wilson and Youngner's screening criteria issued by the published by the World Health Organization in 1968. With regards to, so those are the criteria which look at the, for example, the cost of a screening test, its acceptability, and looking at whether the disease is well understood and has a detectable early symptomatic phase.
Good. So the Wilson and Junker has got 10 criterias. You will be never asked all the 10 criterias, but you will start saying in the exam as if you know all the 10, so that fluently if you say even 4 or 5 criterias, that facilities for diagnosis and treatment should be available, and the disease should have a early latent phase, the test should be suitable, test should be applicable to the wide population, natural history should be known. So like that, if you understand and try to say few, the examiner will stop and take you forward. Okay?
Yeah.
Always in the exam, the examiner will take care of you to progress to the higher mark questions. Whenever you are correct, they will not allow you to complete the full answer. They want to take you into the deep waters. And as you reach higher questions, your marks will be always good. Good. Um, and this PLCO study, as you said, is bit corrupted due to the people in the control arm also getting tested. That's a usual US way. But ERSPC showed that there is a good positive effect for screening. But in UK, measuring the pros and cons with our nice guidelines and NHS setup, we have decided not to go for a general population screening, but we still do a specific screening. For example, patients coming with visible hematuria, we do PSA before flexible cystoscopy, etc. So what do you think about this patient's further management? You has the history. This patient has no medical comorbidities, no family history. His PSA is increased 4.2, 55-year-old, healthy. So what are you going to do further?
Well, I want to perform a chaperoned physical examination as well to focus specifically on the presence of any suprapubic or loin tenderness or masses, any abnormalities of the external genitalia, and also performing a genital examination to assess the prostate size and the presence of any nodularity and irregularity, and also to assess the anal sphincter tone and saddle sensation throughout any peripheral neurological compromise. Given that the PSA is elevated as per the NICE guidance, but also for this patient's age range, I will counsel them about the potential implications of an elevated PSA, including that of prostate cancer, and I will offer him prostatic biopsies with a preceding multi-parametric MRI scan of the prostate to look for any targetable lesions. I will also offer him PSA surveillance. For example, if this were an isolated PSA raise, there's no family history of prostate cancer, and he has a benign feeling prostate.
Okay, he has a benign feeling prostate. So what is your next step?
So as I mentioned, I will offer him either a prostate biopsy with preceding MRI scan. In doing so, I will counsel him about the biopsy itself using a bowel consent form and information leaflet, explaining what the procedure involves, the benefits in obtaining a diagnosis, and the risks, including bleeding in the sperm, urine, or rectum, depending on the route, acute urinary retention, risk of sepsis, and that the biopsies may miss small areas of cancer, and he may need repeat biopsies to be performed.
Okay, at this stage, Pish, as per the EAU guidelines, we are not supposed to do biopsy with just one increased PSA value. So the correct answer will be you will be repeating the PSA value. If it is normal, you can hold on. Maybe you can even discharge back to the GP stating that PSA is normal, examination is normal. Please keep an eye on the PSA and refer back if needed. But if the second PSA is also in the abnormal range for his age, we can go ahead with MRI followed by the prostate biopsy. What type of MRI you are going to request for this patient?
I'll request a multi-parametric gadolinium enhanced MRI scan. This looks at 4 specific sequences, which are T2 weighted and T2 weighted with contrast, diffusion weighted images, and images using the apparent diffusion coefficient. There are sequences which are looking for abnormalities in different zones of the prostate. So the T2 weighted images look specifically for transitional zone lesions, whereas the DWI and ADC images are looking specifically for abnormalities within the peripheral zone of the prostate.
Okay. Any specific evidence you have to support using MRI before biopsy?
The evidence for this comes from the PROMISE and PRECISION trial. In PROMISE, all men underwent multi-parametric MRI followed by transperineal and truss biopsies. And this was found to have a greater sensitivity compared to truss biopsies in the detection of clinically significant prostate cancer. Precision looked at the use of targeted biopsies with preceding based on identifiable lesions in MRI compared to systematic truss biopsy, and found again a greater detection of clinically significant prostate cancers, as well as a low detection of clinically insignificant prostate cancer. So both studies concluded that the use of multi-parametric MRI allowed for a greater detection of clinically significant cancers, but also to avoid biopsy for cancers which are overall turned out to be clinically insignificant.
That's quite detailed. The usage of these two papers, if you are so nicely studied, I prefer you to bring yourself voluntarily quoting the studies. It will be nice if you can quote the studies only in 2 tables in the FRCS: benign prostate, BPH. There are a lot of papers, and also in prostate cancer. Rest of the tables, don't even worry about any studies. Maybe 1 or 2 rarely here and there, if you want, you can bring in. But prostate cancer and BPH, try to bring in some studies because they are really good and quite important. Very good. Your patient had Pyrite 4 lesion in left peripheral zone. His prostate volume is 40 cc. PSA density is 0.13. Now, you have already counseled him regarding the biopsy. He is attending for the biopsy. What type of biopsy you are going to plan for him?
The type of biopsy will, the routes will depend on what is available within the unit. In my practice, this is via the transperineal route. So I'll plan for a local anesthetic transperineal biopsy. And sorry, did you mention that there was a Pyrite 4 lesion on the MRI?
Yes, on the left peripheral zone.
Okay. So I will plan for systematic biopsies, but for the left peripheral zone to be targeted with more cores to be taken from that particular area.
Okay. His PSA density is 0.13. What is PSA density? How will you calculate?
This is calculated by dividing the PSA by the ellipsoid prostate volume, which is calculated by multiplying the height, width, and length in centimeters, and then multiplying that value by 0.52. A PSA density of greater than 0.15 is associated with a high risk of prostate cancer.
Okay. Transperineal biopsy. Just take me through the steps, like how will you give local anesthesia and what is your antibiotic policy?
So antibiotic policy will be to administer a single dose of oral ciprofloxacin prior to the procedure. In my practice, I administer local anesthetic 1 centimeter either side from, so 1 centimeter superolateral to the anal verge on either side, and to give local anesthetic to the skin and to the slightly deeper tissue.
Okay. And are you using any grid? How will you guide your biopsy needles?
The biopsy needle, so for all the local anesthetic transperineal biopsies I'm currently performing, there's no grid used. However, an ultrasound, I'll place the patient in a lithotomy position, place an ultrasound scan, a transrectal ultrasound probe to image the prostate. I'll obtain sections in the axial and sagittal sections. And using the perineologic device, I will insert the needle through the perineum and guiding it into the prostate.
So a patient will be awake under local anesthesia, legs will be held up in stirrups.
Yes.
Okay. So how many courses you are going to plan for this patient?
I'll plan to take 24 cores in total. So 24 cores in total in terms of systematic biopsies, but I will plan to take more cores from the left peripheral zone, and I'll review the MRI images myself and plan where exactly these will be taken, whether it's from the base, mid-zone, or the apex, depending on where the lesion is.
Any specific reason you are taking 24 course?
So this is based on the Ginsberg protocol, but I don't know any more details apart beyond that.
Okay, so in that 24 itself, you will include your targeted left peripheral zone, which is showing suspicious areas in the MRI. Okay, that's good. We are waiting for this patient's prostate biopsy result. And how will you classify these lesions in the MRI? How are you able to interpret the MRI images?
So the interpretation is using the Pyrite Scoring system, which stands for Prostate Imaging Reporting Data System. There is also a Likert system, and a Pyrite score goes from 1 to 5, with a score of 1 being very unlikely to represent prostate cancer. A score of 3 is equivocal, and a score of 5 is highly likely, very highly likely to represent malignancy. This score is assigned to both the peripheral and the transitional zones of the prostate. And this also depends upon enhancement of any lesions with the administration of intravenous gadolinium contrast.
Okay. You did a course as per your planning. Of all the course, 4 course came positive for Gleason 3 plus 3 prostate cancer. All the 4 course were in the left peripheral zone as expected. All the course were less than 50% of the length involved. So, how are you going to take this forward?
I'll discuss this patient's case in the urology MDT. In terms of further management, I'll recommend. So he, as per the NICE stratification, he is in a low risk group, as he has a PSA of less than 10, Gleason score of 6. May I ask what the clinical staging is as well? Is it T2A?
No, clinically his prostate was normal.
So less than T. So yeah, less than T2 clinical staging. So I'll recommend that this man be placed on active surveillance, and it's also grade group 1 cancer.
Okay, so how will you explain this to the patient?
I'll explain the results to him in a prostate results clinic with the urology cancer nurse specialist present. I will explain to the patient that whilst he does have a prostate cancer which has been detected and diagnosed, it is of a low grade with a low chance, low risk of metastatic disease, and therefore he could be offered active surveillance. And I'll explain to him that this means a very close monitoring of his PSA based on the NICE protocol, which in the first year would consist of 3 monthly measurements, measuring PSA kinetics, including PSA velocity and doubling time, and also repeating his MRI scan in 12 to 18 months. If there are any concerns about his PSA value and repeat digital rectal examination, then this would be an indication to perform a repeat MRI scan and consider repeat biopsies, with a view to progressing to radical treatment if his cancer has been demonstrated to progress.
Okay. So how will you calculate his PSA velocity?
So the PSA velocity relies upon 3 PSA readings to be taken over a period of time, and it's also relies on knowing the time frame between the PSA values, which is measured in years. It's calculated by the PSA, the third PSA reading minus the second reading divided by the second time frame, added to minus, I think it's added to the similar calculation for the second and first PSA readings and the first time frame, and multiplying that value by 0.5. PSA velocity of greater than 0.75 is considered significant and requiring requiring further diagnostics.
Okay, there is also online platforms available. If you just search in any browser PSA velocity calculator, you will get an online form. You just enter 3 values 3 months apart, and then it will automatically give you PSA velocity. That's more quicker in the clinic setup.
Yeah.
Okay, so you offer this patient active surveillance, patient accepted. What is your next plan?
So I will arrange this patient to be seen again in the clinic, ideally seen again in the clinic in 3 months. I will provide him a blood form to repeat his PSA, and I'll ask him to get this PSA measured 1 week before his clinic appointment. I'll also provide him with the contact details of the urology cancer nurse specialists.
Okay, it's always you will be having the cancer nurse specialist when you are disclosing the cancer diagnosis. So most probably they will be in the clinic with you. So what is the follow-up regimen you said for the first year?
So for the first year, the protocol is to measure the PSA every 3 to 6 months, to monitor the PSA kinetics in the form of the PSA velocity, and to perform a digital rectal examination at 12 months following diagnosis, and to repeat an MRI scan at 12 to 18 months.
Okay, if everything is stable and the velocity is an acceptable velocity, after second year, what is your treatment plan?
At the second year, I will then arrange for the PSA to be measured on a 6 monthly basis, but again, monitoring the PSA kinetics. And if there are any concerns, and also to perform an annual digital rectal examination, and if there are any concerns of any of these, then to perform a repeat MRI scan.
Okay. What kind of leaflets you will be giving the patient to take home?
I'll provide him with information leaflets from Prostate Cancer UK on active surveillance, but also which will contain information not just on what active surveillance involves, but also any symptoms that patient themselves will need to be concerned about, and to contact the department for expedited appointments if they experience any of those.
Okay, there is a Bow's information leaflet on active surveillance, which is quite a new one. It's a nice one to mention in the exam also.
Yeah.
Okay, good. I'm quite happy to stop the discussion here since you have the on-call to follow this. No major concerns from my side. Everything is smooth, and I'm happy with the face, and I'm happy with the vocation, speed. No problems in communication. Knowledge-wise, fantastic. As I mentioned here and there, few things possibly you can revise this video and get into the depth in those areas also. This is just a starting. You have plenty of time. If we manage the same knowledge and same pace, I'm very sure you can really master all the tables in the same wavelength.
Yeah.
I have no concerns at all. Maybe they can ask a little bit about the PSA biomarkers and those things which you may have to keep an eye.
Yeah.
And since you're good, try to bring in some values whenever you can, some mention some percentages and values, and have a paper and pencil in front of you even in the training sessions like this, because in the actual exam you will have a paper and pencil in front of you,
Okay.
so that whenever the examiner gives you a PSA value, age, examination normal, any values, you can start scribbling on that so that you don't have to ask the examiner again. And so that it becomes an habit for you. And at one point, we may even ask you to draw some diagrams or flow chart, and use a camera to share with us so that we can test those things also.
Yeah.
Very good. I have no concerns at all. Anything from you, Piyush, to add?
So I just wanted to ask regarding which guidelines to refer to, because the NICE guidelines, I think, for prostate cancer, they're robust in terms of the primary care referral. And in terms of secondary care management, though, I found the EAU guidelines to be a bit more robust and in depth.
Yes, EAU is definitely robust because it is developed over many, many years, and also it has minds of many people from many countries. So it is nicely evolved and matured now. Definitely read EAU guidelines, there is no doubt in that. But at any point, if EAU is slightly different from NICE, try to stand on the NICE and try to refer the NICE. For example, the follow-up protocol in active surveillance may be slightly different in EAU, but NICE guidelines follow-up protocol is more than enough for the NHS setting.
Yeah.
So try to absolutely aware of the NICE guidelines and try to use it. And EAU will be the main player card for you. But if there is a discrepancy between the NICE and EAU, stand on the side of the NICE, and that quote. In fact, in the exam, you can say, as per the NICE guidelines, I will do this, but I'm aware in EAU guidelines the values are slightly different, and you can mention that also. That will really fetch you more marks.
Yeah.
Okay, very good.
Yeah.
So try to restrict the discussion only to that particular patient, and you are absolutely fine. I'm sure everything should be good. Okay,
Okay. Thank you very much.
good. Have a good on call. Should everything go very smooth.
Thank you very much, Mr. Sacred.